So, a very good morning, everyone. First of all, I would like to thank AIOS Support Organizing Committee for organizing such a virtual fest. And secondly, I would like to thank Dr. Shell for including me in this wonderful comorbid IC on cataract. So, I'm Dr. Deepak. I'll be talking basically about managing the retinal aspect of a patient and a diabetic patient who is planning a cataract surgery or who has been diagnosed with a cataract. So I'll be sharing a few of real world scenario cases which will help us to imbibe practice patterns in the managing in such patients, diabetic patients who have multiple comorbidities. I'll focus on the retinal aspect only in most of the cases. So let's talk about a tale of two simple straightforward cases. One is a 55-year-old gentleman, recently diabetic for 2 years, has a significant cataract, no retinopathy at baseline examination, as compared to an aged lady who has been diabetic for the last 22 years, has a visually significant cataract, no retinopathy to begin with. So on examination, if you see, if you have to do a meticulous retinal examination along with your cataract examination. So whenever you see a cataract patient and a diabetes, it is must to rule out a posterior pole disease, because it is the posterior pole which is going to be important for giving the vision to the patient back. So for examination, sometimes a fundus photo can give you a clue that is no retinopathy. Still, we have advanced technologies like OCT to document clinically microscopic changes, sometimes early retinopathy, which may not be seen on fundus photos. You might be able to pick up very early changes in OCT, and that is why it is mandatory for this diabetic patients who are a little bit more prominent, for who are telling you that I would like to go a premium IOLs. It's better to get a mandatory OCT examination done in such cases. So post-operatively, the young gentleman, 55-year-old gentleman, he was quite happy with multifocal IOL placed enterally, and posterior segment also OCT also shows the same what we had in pre-operative. But that lady, aged lady, unfortunately at 3 months she was not happy, and on OCT we are seeing some changes happening because of retinopathy. On fundus photo, she didn't had any retinopathy to begin with. After cataract surgery, I could see some background retinopathy to happen with. So what went wrong? So I reviewed the surgical records back. The cataract surgery was flawless. It was performed by Dr. Shell, and I could not find any error during the pre-operative period or even on the first month post-operative period. So what went wrong? So diabetic retinopathy can develop after cataract surgery. It is very important to know this. So one of the risk factor for developing a diabetic retinopathy is cataract surgery. Also, there are many other risk factors which would I like to highlight. You can put it on the checklist whenever you are seeing on a diabetic patient who is planning a cataract surgery, like duration of diabetes, patient who have early onset juvenile diabetes, patient who have comorbidities like nephropathy, neuropathy, patient having blood pressure issues, cholesterol issues. So these are the red flags for developing retinopathy after cataract surgery. So newer associations, aged patients, women, and patients who are using AC inhibitors, statins, dyslipidemia, and insulin lesions, these are the newer risk factors once we get more insight into the diabetes per se. Why does cataract surgery causes retinopathy? Because cataract surgery itself can cause compromise in blood retinal barriers, because being a surgical trauma, and also the inflammation. If you have an eventful cataract surgery, it may initiate a cycle of progression of diabetic retinopathy. And what is the incidence? So overall incidence of pseudophakic CME after cataract surgery is less than 1%. But if you have a diabetes, if you're a patient undergoing diabetes, the risk of macular edema developing after cataract can be as high as 50%. So you might be very aware of this. So when to plan a cataract surgery in a diabetic patient, please do not wait for too long, especially with patients who have PSC. A classic diabetic cataract presents with PSC. And if you have a long-standing cases, the nuclear sclerosis along with the plaque forms, which will cause more interventional procedures during the surgery, which will end up not with a not happy patient. If the fundus is not visualized clearly, always inform the patient that there may be post-op surprises, no matter what you do. Pre-operative workup, this is a basic checklist, the highlight being a patient counseling. So the patient should be counseled that diabetes per se can cause retinopathy, cataract, corneal problems, other problems also including glaucoma. So he should be made aware about the concept called as diabetic eye disease. So he should be made aware that it is a small part of a big spectrum of disease which is called as diabetic eye disease. Once the patient accepts that he is suffering from a diabetic eye disease, and cataract surgery will help him little bit more, especially if there are no any other comorbidities. So he will accept your whatever lenses, whatever post-operative regimens you have. It's very important that if there is any pre-existing retinopathy or diabetic macular edema and there is no visually significant cataract, we have to treat the diabetic retinopathy, the retina, first before you perform a cataract surgery. Do not ask these patients to undergo cataract surgery first without treating the retinopathy pre-existing, because they may not be happy. So now coming to the treatment options for macular edema. So overall preferred, if you have a central mode, fovea involved retinopathy, the standard treatment of choice is intravitreal injections. It can be anti-VEGF or steroids. If you have a non-foveal retinopathy, laser is the standard of choice. But overall mandatory is systemic control, which should be emphasized at every visit. Considering steroids and anti-VEGF, this is a $1,000,000 question. And if out of pre-operative, the patient is not planning cataract surgery, anti-VEGF is the first standard choice. In the perioperative period, if the patient is planning cataract surgery, we have found out that steroids are a better drugs as compared to anti-VEGFs. So timing, when do you plan intravitreal injection in a patient who is planning cataract surgery in a diabetic patient? Recent reports have told that the best timing is intraoperative, concurrent injection, let it be anti-VEGF or a steroid implant. It's very important whenever you have a patient with diabetic retinopathy and he comes, you have to distinguish it from pseudophakic CME. Pseudophakic CME, because the prognosis is very good, it is self-limiting disease compared to DME where you have a background retinopathy. So coming down to the second case, he's an aged gentleman, known case of retinopathy, has received multiple injections. Now he's been advised cataract surgery. So on retina, everything was good. The patient underwent cataract surgery, but he was unhappy because he did not find any visual gain. Why? Because diabetes per se is the vascular disease. So whenever you have a mismatch between the cataract grading and the visual acuity, best corrected visual acuity, you have to suspect some kind of ischemia in diabetic patients, and which is better shown on angiography or OCT angiography, which is now available. So we have to be aware of poor prognostic indicators that pre-existing retinopathy is a red flag sign. And if there is a poor presenting visual acuity, despite the cataract grade or retinopathy doesn't meet, always suspect the ischemia. Coming down to the third case, sometimes whenever you have DME, all these patients do not need injection. So when you have a tractional component like this patient who had a tractional component, only performing cataract surgery with injection will not work. You have to first get rid of this traction. So for traction, we have to plan a retinal surgery first if the cataract is not very demanding, or if the cataract is very significant, you can plan a combined cataract surgery along with the retinal intervention in the form of removing the traction, in the form of vitrectomy and peeling all the membranes on the scaffolds, epiretinal membrane and the IM scaffold. So these are surgical patients. Not all diabetic patients will need a injection per se. Coming down to the fourth case, so here you can see he's an aged gentleman, he is a diabetic patient, multiple interventions, he comes for a cataract treatment. I want you to highlight on this posterior segment OCT. So if you see, I cannot distinguish any of the retinal layers distinctly. So he basically has a foveal atrophy. So if you are seeing a patient with a foveal atrophy, these are not the candidates for premium IOLs, and they should be counseled for real world visual expectations. So they should not be expecting a miracle happening after cataract surgery, because the vision potential, whenever you plan a cataract surgery, you have to see a vision potential of the patient. For assessing the visual potential, you have to see the optic disc and the macular also. Finally, a last case like this, if you see a severe retinopathy, these are very, very big red flags for a cataract surgeon. Whenever you see a vitreous hemorrhage, tractional retinal detachment, florid neurovascularization, these are straightforward cases for retinal intervention. Unless and unless the retinal colleague tells you that you can cataract is very significant, he is not able to see a retina very clearly. Only in such specific scenarios you can plan a combined surgery. Otherwise, you have to schedule these patients for retinal intervention first to see what is the vision potential. Then later on, you can plan your cataract surgery if the patient is accepting your suboptimal intervention in the form of retinopathy. Lastly, to end it, we should not forget the diabetic patients care is a risk factor for glaucoma as well as other diseases like AION. So we should, whenever you are seeing a retina per se or a cataract per se, we should always be aware of all the comorbidities associated with diabetic patients per se. So to conclude, the real world problem with diabetic patients is we are not living up to patients' expectations, because the patient expects that this is just a cataract surgery, but diabetes is not like that. So we have to educate the patient that you are suffering from a diabetic eye disease, not a straightforward cataract, not a retinal disease also. And we have to see eye as a whole, not as a cataract, glaucoma or retina, anything anything. And please don't be overzealous in performing refractive cataract surgery in patient with diabetes. Thank you very much for your patient listening.